Hello, everyone. It's
Uh,
17 CET, and
yes,
I welcome you all to LMHI Global Colloquium 2021, where it says homeopathy, a medical science ahead of its time. Ladies and gentlemen, I extend a very warm welcome to our honorable chairpersons, our honorable moderators, and to all our honorable speakers. The host nation for this is Turkey, and our honorable chairpersons are Honorable Dr. Gustavo Katladi and Honorable Dr. Alpune Agalku. Our honorable moderators are Honorable Dr. Lebanon Buddha and Honorable Dr. Gokhan Center. A very warm and fine welcome to all of you. Now, with the permission of our honorable chairpersons, I would take this forward.
Thanks.
Thank you.
Thanks,
Would you love to take it forward, sir, or shall I do it?
I'll do.
Thank you.
Thanks.
Thank you so much,
Thanks.
sir. Over to you.
Thanks. I'm co-chair with Altunay Agaguglu here, and it's my pleasure to be chair of this session. The first work is from Jennifer Jacobs about a research of long COVID. Jennifer Jacobs, MD, is a retired family practice physician who specializes in homeopathic medicine. She is also a clinical assistant professor in epidemiology at the University of Washington School of Public Health and Community Medicine. She is also a past president of American Institute of Homeopathy. And there are many, many titles more, but I think it is good to go ahead and go directly to your presentation. Please, Jennifer.
Thank you. Thank you for the introduction. I'd like to go ahead and share my screen, which is my PowerPoint presentation. And I can take you through that. So this is a study that we're doing on the homeopathic treatment of long COVID. It's being sponsored by the Southwest College of Naturopathic Medicine and Dr. Elizabeth Rice is the principal investigator. Dr. Rice is the chair of the homeopathy department there at SCNM. So before we get into the study, I'd like to just review a few points about long COVID. I'm sure most of you know about this. Long COVID is a syndrome that is characterized by persistent symptoms after the acute phase of COVID-19. The definition varies among different people. Different research articles define it as either symptoms lasting more than 30 days or symptoms lasting 60 days or some even more than 12 weeks. In our study, as you'll see later, we use the definition of symptoms persisting past 60 days or 2 months. What's interesting about long COVID is that it can occur in people even who've had asymptomatic disease, and it's also being reported in people who've had breakthrough cases, that is, people who've been vaccinated but still test positive for COVID-19. Again, the studies are varied. Some people say it occurs in 10% of people who've had COVID, others up to 50%. But considering how many cases there have been of acute COVID worldwide, over 270 million cases over the whole world, 50 million in the US alone, you can see if only 10% of people have long COVID, it's still a huge number of people with serious symptoms and sequelae that are very difficult to treat. One of the most recent articles on prevalence of long COVID was a systematic review published in JAMA a couple of months ago. In this review, they looked at 57 studies with more than 250,000 COVID-19 survivors. The mean age was 54.4 years, 56% of them were male, and 79% had been hospitalized. Now, this is a group that has been hospitalized, which is going to skew the results, I think, more towards positive long COVID. But in this study, the systematic review, they found after 1 month, after 2 to 5 months, and after 6 months and more than 50% of COVID-19 survivors had one or more symptoms of PASC or long COVID. The conclusions of this systematic review I thought were interesting. First of all, they said that these effects of PASC occurred on a scale that's sufficient to overwhelm existing healthcare capacity, particularly in resource-constrained settings. And also, they advised that clinicians must work towards a holistic clinical framework to deal with the effects of SARS-CoV sequelae. So a holistic clinical framework. This sounds like it could open the door to homeopathy. So the symptoms of long COVID are myriad. In fact, it's been estimated that every system of the body can be affected, and there have been over 200 reported symptoms in various studies. The most common is fatigue. More than 80% of people report having fatigue, and this fatigue can be physical or mental. Also, cognitive dysfunction, which people often describe as brain fog, not being able to concentrate, losing their train of thought, and also memory problems. There's also a lot of anxiety and depression. Again, 60 to 70% report this. Headaches, sleep disturbances, shortness of breath, muscle aches, loss of smell and taste. As I said, almost any system of the body can be affected by this. So it's still unknown the actual cause of long COVID, but many people feel like it's a multifactorial event. This slide shows some of the different mechanisms that contribute to long COVID, and it would vary from person to person. You have here the acute infection, the inflammatory phase, and the recovery of the acute infection. One of the causes of long COVID could be the treatment people receive, which causes drug side effects. There's also cytokine storm, complications, comorbidities, altered immune status, which can cause infection, inflammation. Some people have postulated that it could be due to antibodies that develop against the ACE2 enzyme during the acute phase of the study. There's also the psychological issues, which I think are very prominent, and that is the effects of isolation during the pandemic, the psychological issues of having the problem, of having COVID, of missing work, of being isolated from family and friends. All of these things have been targeted as possible mechanisms that lead to the prolonged symptoms of long COVID. So, as I said before, up to 50% of acute COVID patients go on to have long COVID. And the symptoms are varied, as I mentioned before, But what's important and what led us to decide to do this study is that there's really no current conventional treatment for it. Patients are often referred to various specialists, cardiologists for their heart problems, pulmonologists for shortness of breath, physical therapy for their fatigue. Many of these long COVID clinics refer people out to several different specialists. So we saw this as an opportunity for homeopathy because, as we all know, homeopathy treats the whole person, physical, emotional, and mental symptoms, and therefore could be an ideal treatment for long COVID. So in our pilot study, we are treating between 60 and 70 patients who are being randomized to receive either an individual homeopathic medicine or a placebo. All patients are undergoing an intensive homeopathic interview with a provider, and then follow-up visits are being made at 4, 8, and 12 weeks. We are using a program called REDCap to administer the surveys for the study, to do the data collection and the analysis. And I'd like to just tell you briefly a little bit about REDCap, because we found this to be very helpful in carrying out the study. So REDCap is an international research consortium, which is available at no cost for nonprofit institutions. So I would encourage all of you who are doing research within institutions to consider looking at this. It's a secure and web-based platform to build databases, surveys, and input data. There's access from multi-sites. There are modules available for scheduling and tracking participants, and you're able then to download the data to various statistical programs, including SPSS, data, etc. So our objectives in this study is to gather data for a large, more definitive study. So it's really a pilot study, a feasibility study. And these are our main objectives: to identify means of recruitment, to test the study design and protocol, to evaluate the outcome instruments, to estimate sample sizes for a full-scale trial, to determine the medicines that are most often prescribed, and to determine if there's a measurable effect size difference or positive trend in the patients that are treated. Patients in this study are ages 18 to 64. They have to have had a positive PCR test. This has been a difficult thing because of many of these survivors had COVID early on and they don't have this, but for scientific rigor, we need to require that they have a positive PCR test. They need to have had persistent fatigue for at least 60 days since their diagnosis, at least one other symptom consistent with the syndrome, and a fatigue assessment scale score that's greater than 21. So the fatigue assessment scale has been well used and validated. It contains 10 statements about how a patient usually feels. And there are 5 answer categories, 1 to 5, ranging from never to always. So we are administering this assessment scale during our eligibility survey. And anyone who has a score of over 21 and also meets the other study requirements, we are bringing into this study as a possible participant. We do have many exclusion criteria: previous hospitalization in the ICU, previous diagnosis of chronic fatigue, fibromyalgia, Lyme disease, or psychiatric or neurological illness. If they're taking steroids, opioids, or biologic immunosuppressives, they are excluded. Also, if they have clinically significant kidney, heart, or liver disease or active cancer. And also if they're currently being treated by a homeopathic provider. So the treatment, I want to emphasize, this is an effectiveness study. This is a look at how homeopathy is practiced in the real world. It's not an efficacy study where specific medicines are given. So the providers in the study are all licensed homeopathic doctors, either MDs or naturopathic physicians. They carry out a comprehensive homeopathic interview. It's done over video. It's a virtual study, which has come with many complications, but the video that's used, the video platform, is HIPAA compliant. The practitioner is free to determine the dosage and repetition of the dose, and it can be changed during the study. All remedies prescribed must be in the HPUS, the Homeopathic Pharmacopoeia of the United States, and they're mailed to the patients by priority mail by the Hahnemann Laboratories in California. And the patients, obviously, in a clinical trial are randomized to receive either verum or placebo. It's all blinded. The only person who knows what patient is getting what type of medicine is the pharmacist, and we will not break the code until after the data analysis is completed. So recruitment has been the most challenging part of this study. We've been recruiting people over the internet through Facebook ads, and also through survivor groups, Facebook survivor groups for people who've had COVID-19. And we're directing them to the states where our providers are licensed. The advertisement takes people to the Red Cap recruitment survey, and if they are qualified by the survey, they're scheduled to discuss the study with our study coordinator and sign the informed consent. At that point, the patient is assigned to a provider and directed to contact them for an appointment. So recruitment has been difficult. As I said, we started out with this type of an ad, which is emphasizing the $100 gift card that we're offering for people who complete the study. But we decided also to try a more altruistic approach. So this is our next advertisement that we've been using, Help Others Overcome Long Haul Symptoms. And we're going to be analyzing and seeing which type of recruitment is more successful. Many of the people that answered the $100 ad seem to be only interested in the money. And so we'll see what happens. There's also one more. We had an Instagram influencer who put out a call for our study, and she put together this graphic that also resulted in several hundred people answering our call for participants. So the outcome measures are happening at baseline, 4, 8, and 12 weeks. The primary outcome measures, which have been validated in many, many studies, the SF-36 Quality of Life Survey, the Fatigue Assessment Survey, which I mentioned previously, and then we also have some exploratory secondary outcomes, the MyMop, which is a measure where people are able to list their 2 most bothersome symptoms. And we are rating these at the beginning of the study and at the end. The FAS at week 4 to see how many people have improved just after the first 4 weeks. And we're also testing a patient health questionnaire 9, the PHQ-9, which is a depression measure at the beginning, at the end of the study. Since so many people have depression, we wanted to look at that. The statistical analysis, we're going to be using the t-test or chi-square for the demographic and baseline data. We're going to use repeated measure analysis of variance for the SF-36 and the FAS. over 4, 8, and 12 weeks. The MyMop and PHQ-9 by t-test or Wilcoxon ranks some, if not normal. And we're going to use the variability of the fatigue assessment scale to determine the sample size estimation for the full-scale trial. So our progress to date. Well, we did receive IRB approval. That was back in May, and we recruited 22 providers from 10 states. You can see the list of states here. We wanted, even though it's an online virtual study, we felt it was important that the providers see patients in states where they are licensed. So we've had to restrict the number of states that we're recruiting patients to those in which we have providers. But we do have 22 providers. Thus far, we have enrolled 44 patients. Well, this was as of Wednesday. I just received word this morning that we're up to 46 now, as several more are scheduled or assigned to providers. And we're hoping to complete the enrollment of 66 is our target by the end of next week. So we'll keep our fingers crossed about that. So I looked at the medicines that have been prescribed at the first visits thus far. As you might expect, they've been mostly polycrests, sulfur, natrimur, 5 each, sepia, lycopodium, pulsatilla, arsenic, rust tox, phosphorus, calcarea, and stanum. There have been 2 stanum prescriptions. And then other remedies that were only given once are listed here. And at this point, we don't know who's received Verum or who's received placebo. Some of our providers have reported that their patients have done very well after the first visit, and others have said they've seen no change. So we'll have to wait until we analyze the data to see if indeed this correlates to those who receive placebo and those who receive Verum. So I want to emphasize that this is a true collaboration of the homeopathic community here in the United States. The providers, all 22 of them, are volunteering their time to see the study patients. I should say previously that we do not have any grant. This is a pilot study that we're kind of doing on this spur of the moment. And so we're relying on the collaboration, the generosity, and the charity of the homeopathic community here to make this pilot study possible. Where our hope is that we get results that look positive or have a positive trend, so that we'll then be able to go to the NIH or other large funding organizations to get funding for a large scale trial where we will be able to pay the providers who are volunteering their time. And they originally agreed to see 3 patients, but some of them have agreed to see an extra one. Again, Hahnemann Laboratories are donating the study medicines, and they're also donating the priority mailing of the medicines to the patients. We did get a grant from the Samueli Foundation to pay for a part-time study coordinator. We realized that there are just too many pieces to this. 22 providers seeing 3 or 4 patients each is just very difficult to take care of and to keep track of without having a dedicated study coordinator. So we were fortunate enough to receive a small grant to pay for that. Also, SCNM, Southwest College of Naturopathic Medicine, has been very generous with their resources. Dr. Rice has spent much of her time working on this study. Their public relations department has helped us with recruiting, and the homeopathy department has had some funds that they have dedicated towards the study. In addition to these things, we've also had private donations from individuals. These are often homeopathic patients homeopathic supporters. We've had Facebook marketing help from a homeopathic enthusiast who is an expert in that. But our biggest help in recruitment has been from social media influencers. I guess those are the keywords these days, influencers. Americans for Homeopathy Choice, specifically Paola Brown, gave us a big boost by sending out a call on her Instagram feed for participants. The naturopathic physician I mentioned that had this cute little graphic has brought us a lot of patients. And then also the COVID care group, which is a long COVID survivor group, has featured our study on their website and on their Facebook page. So all of these things together have brought us to the point where we're on the verge of reaching our target study population. And as I said, we're hoping to finish our recruitment by the end of next week. It will be probably the middle of March before the actual study data collection is done and all of the patients have finished their time in the study. And then I'm sure it's going to take us 2 or 3 months to do the data analysis and so forth. So hopefully by the beginning of next fall, we may have some results for you on this study. If you want to know more about this study, this is our website. You can go there if you know someone in the US who might want to participate. We still have a few spots. There's a link there to our eligibility survey. And I would be happy to take any questions that anybody has at this point. It looks like we still have 5 minutes left.
Gracias, doctora Jennifer Jacobs. Le voy a hacer, yo tengo un par de preguntas para hacerle antes de pasar al doctor Gorkan, que va a presentar a la próxima, a la próxima speaker. Jennifer, los síntomas de COVID largo que ustedes están evaluando, o sea, la indicación del remedio es una indicación de acuerdo a síntomas generales, como usted presentó, de acuerdo a síntomas característicos o de acuerdo a síntomas particularizados, individualizados, tratamiento individualizado de cada paciente. Y eso por un lado. Okay.
Yes, well, fortunately, I do understand Spanish because I don't have translation. But we are focusing on the symptoms that the patient has had since the COVID-19 illness. Of course, we're looking at their long-term symptoms as well, but we're mostly focusing on symptoms that have come on since their illness of COVID-19. Although you see by the list of remedies that many of them are polycrest, but some of our providers have reported that the chronic symptoms that the patient have had prior to their illness became more prominent after the COVID-19. So they still needed the same remedy as before. Others have had new symptoms that they've never had before. And in those cases, the prescription is being made on that basis.
También ustedes seguramente en el grupo han, do you have the translations open?
I wasn't given any information about translation, but I can understand Spanish if you speak slowly.
Okay. Okay, I can speak in English too. Do you take into account if the patients received an individualization in the treatment previously COVID? First one. if the patients were homeopathized, and second one, if you make differences between the long COVID in vaccinated and not vaccinated persons.
Excellent question. Excellent question. This came up originally. We had an eligibility requirement that people be vaccinated prior to starting the study. Now, this was controversial among our group, but the reason we did this was we didn't want patients to be vaccinated during the study because we felt that could interfere with the homeopathic treatment. And if there was a change in how they were, we couldn't decide whether to attribute that to the vaccination or to the homeopathic treatment. So originally we required that all people in the study have already been vaccinated. Like I said, this was controversial because why would someone who's already had COVID get vaccinated? But anyway, but then the booster came on the scene. And all of a sudden we were faced with the problem, okay, what if people gets a booster during the study and how will that affect things? So at that point we decided if we can't tell people not to get a booster. So if we're going to have to deal with the problems of people getting a booster, we decided to also start allowing people into the study who were unvaccinated. So we did this about halfway into the study. So now we do have some people in the study who've been vaccinated and some who are not vaccinated, and we'll be able to compare their results. And we're also keeping track if anybody gets boosted during the study, and we're going to have to adjust for that too. So it's a very complicated situation we're in, and especially because we didn't feel like initially we could tell unvaccinated people not to get vaccinated during the study, which is why we excluded them. But then we realized, well, by now, whoever's not vaccinated is probably not going to be.
Okay. Thanks, Dr. Jennifer Jacobs. For sure, many questions are coming. Dr. Gorkan, Dr. Levin Buda from Turkey, please go ahead with the next speakers.
Welcome.
Hi, welcome. Gökhan, you can start now?
Yes, yes.
I can continue. Thank you.
Now we move along to our second session to listen to the very interesting presentation of Dr. Anjali Miglani, who is member organizing team LMHI Global Colloquium 2021. Dr. Anjali Miglani, medical doctor, graduated from Nehru Homeopathic Medical College, has more than 23 years of professional experience as a researcher, teacher, and clinician. As a researcher, worked in Delhi Homeopathic Anushantan Parishad, autonomous body for research under Government of Delhi, and was an integral part of various research projects, especially tuberculosis and various skin disorders. Moving along to our session, please welcome Dr. Anjali Miglani, who will be speaking to us on impact of bias in data collection of COVID-19 cases.
Thank you, sir, for such kind words. May I share my screen, please? Yeah, is it visible to everybody?
Yes, it's perfectly visible.
Yes, perfect.
Thank you. At the outset, I would like to thank LMHI as well as Directorate of Ayush for giving me this opportunity to give the presentation. And it is a privilege to present our work in presence of such esteemed guests as well as chairpersons. I shall be talking on the impact of bias in data collection in COVID-19 cases. Just to give you an overview, why was data collection done in COVID-19? That was one of the main questions. Since it was a new disease for us, our first case in India came on January 30th, 2020, and treatment modalities were not known. So we were also as perplexed as our allopathic counterparts about what to do. But we knew that homeopathy has beneficial effects in influenza-like illnesses. And COVID-19 initially presented more of a URI case, upper respiratory tract infections like coryza, sneezing, and those sort of symptoms. And the USP of homeopathy is that it is not based on nosological diagnosis of the disease. We prescribe more on the symptoms. So that was our USP. So we thought that it is a rare opportunity for us to see if we can do anything good in COVID-19 based on certain scientific methods. Like we know that in epidemics, most of the patients suffer from similar complaints and symptoms. These seemingly common symptoms, they assume importance if prognostic factor research is done, in which case these homeopathic symptoms, they become the prognostic factors that are related to the outcome of the treatment. Our first study was on homeopathic remedies in COVID-19 prognostic factor research. This was done in the first wave from April 2020 to July 2020 at 23 integrated COVID care facilities within Delhi. For this, we are thankful to the government that they actually allowed us to do it. The prescribing indications of 4 most frequently medicines were elicited, which were arsenic, bryonia, gelsemium, and pulsatilla. The details of this study will be taken up by Dr. Meeta Gupta, who is a colleague of mine, tomorrow, that is 11th of December in hall number 3. Moving back to my topic, this is a published study. This has already been published in International Journal Homeopathy. Okay, what is bias? Bias, it is actually a particular tendency, a trend, or inclination, or an opinion, which is especially preconceived or unreasonable. It can be conscious or unconscious. Generally speaking, unconscious biases are activated quickly and unknowingly, despite a person's best intentions. Although we as healthcare providers don't see ourselves as being biased, but it is a common and persistent problem. And if it remains unrecognized or unmanaged, it can result in potentially negative consequences for our patients. So studies on that are very important. As we know that homeopathy is a science of experience that is based on the observations of our practitioners. Therefore, these practitioners should become aware of possible biases in their observations. This requires a great scientific attitude as well as a critical appraisal of their observations. There are many questions to be answered, like how valid is our opinion that the patient's symptoms indicate that particular medicine? Moreover, if those symptoms are actually there or it is a deception of us, we have perceived it that way. The objective of this study was that we wanted to know if there is any bias in this data set, because if there is a bias, then it restricts the generalizability and external validity of that study. Actually, what happened was when we started in April. The virus I had told you came in January. So cases started increasing sometime in March, in the first wave, March 2020. By the time we got the approvals and everything, it was already April. When we did our first study, we realized that homeopathic medicines work. Parallelly, there was another study going on. And in this study, we collected a larger population of patients. But we thought that we have to move a step ahead. If we can do something better, then why not plan an RCT? So that was what the reason for doing this study. So it was very important for us to know whether this study is biased or not, so that if it is not, we can plan an RCT. Otherwise, we have to think further. So we analyzed a set of data qualitatively to detect if there is any possible bias. Then we wanted to explore the reasons for bias, if there were, and what the effect they had on the data, and make recommendations to avoid biases for the future. This was our study design. First, we got the approval. It was an ethical approval. Once we got that approval, Then we started registering our patients. We targeted only those patients who were COVID-19 confirmed patients, either by RAT, that is rapid antigen testing, or RT-PCR confirmed COVID patients who gave us informed consent that they agreed to take our homeopathic medicines, which were given as an add-on therapy to the already existing protocol of modern medicine. That means they were also taking allopathic medicine because we were not allowed to interfere in between. Once we got those target population, then we started prescribing medicines. The medicines were prescribed on totality of symptoms, and our doctors were free to prescribe whatever medicine they deemed fit for that particular case. There was no restriction on that part. And these were open prescriptions. Whatever we were prescribing, we were even telling the patients that this is the medicine we are giving you. The data was being entered religiously on a daily basis in computers. We had shared a custom-made Excel sheet containing 71 fields on COVID-19, which contained symptoms of COVID-19, the investigations part, the mental and the physical symptoms which are required by us as homeopathic physicians. And we even had additional fields wherever we felt that the physician might want to enter some more information. After the whole data was collected, we did the statistical analysis. And the results I'm sharing with you. So this was a prospective open label observational study, which was conducted from April 2020 to December 2020. That was for 9 months. It was basically conducted at 2 COVID health centers, Guru Tegh Bahadur Hospital and Satyavadi Raja Harish Chandra Hospital, Delhi, India. These both are hospital units. Here we got cases which were confirmed mild to moderate, and the data collection was done in a custom-made Excel sheet, as I've already told you. And the follow-up was done on a daily basis until complete resolution of symptoms or up to a week. We used Oradell scale, that is the outcome in relation to impact on daily living, for patient assessment at each follow-up. The follow-up was being done on a daily basis, and our first follow-up usually was at 6 to 8 hours after starting homeopathic treatment in cases where the symptoms were very acute. So only those cases which reported an outcome of Oradell +2. As you can see, +2 means moderate improvement affecting the daily living. In the scale, it is here, which is expected of a homeopathic medicine, because a homeopathic medicine not only seems to improve the main complete, it seems to also improve in the general amelioration of the patient. So this was taken as +2, and the improvement started within few hours of starting homeopathic treatment. And this +2 scale should be achieved within 7 days of starting homeopathic treatment. Out of the cases, 1,889 cases which were collected, which fulfilled this selection criteria. Out of that also, we actually excluded 444 cases. The reason being because 23 cases were asymptomatic, so prognostic factor research cannot be done on those. 134 cases were duplicate entries, because what happened initially, some patients were in the quarantine zone, then they were shifted into the hospital. So somehow or other, those numbers got changed. So these patients were re-entered into the system. So we identified those duplicacies and removed them. And in 287 cases, more than 2 medicines were prescribed. In such cases, it was very difficult for us to establish causality, that which medicine actually helped the patient. So those cases also we did not consider. Only 1,445 cases were considered and analyzed. Statistical analysis, may we use the Bayesian analysis for our statistical purposes, and likelihood ratio was calculated. As we know, likelihood ratio is the prevalence of the symptom in the responding medicine population by the prevalence in the remainder of the population. So by default, if likelihood ratio is more than 1, that indicates that there is an above average prevalence of that symptom in that medicine population, which implies that the chance that a medicine will work if that particular symptom is present in that patient is higher. So the probability of that medicine helping that particular patient also becomes higher. We calculated likelihood ratio for 9 most frequently prescribed remedies. In this case, we got arsenic, bryonia, gelsemium, pulsatilla, hypersulf magnesia muriaticum, phosphorus, nux vomica, and belladonna. And 28 symptoms were analyzed. We also calculated variances of likelihood ratios of the medicines for each symptom and the variations of likelihood ratio of the symptoms for each medicine. The reason for this I'll explain in further slides. The symptoms assessed in this project were mostly common symptoms. So we presume that a moderate LR, that is LR below 5, is sufficient. If we got any outliner values, we deem that if an LR value is more than 5, then that is an outliner value. These are the medicines prescribed. Most of our cases were prescribed bryonia, that is 514, followed by arsenic, then gelsemium. Belladonna was given to 60, as was pulsatilla. Hyper was given in 72 cases, and nux vomica in 19. This is the likelihood ratio graph. Here, as you can see, the symptoms we have written down: cough, fever, fatigue. From this graph, we can actually understand the prescribing totality of certain medicines. Like if a patient has cough, probably bryonia will act the best among these set of 9 medicines. If a patient has fatigue, myalgia, headache, then gelsemium seems to act better. For sore throat, belladonna seems to act the best among these set of remedies. Similarly, if I see dyspnea with productive cough, phosphorus probably will act better. But similarly, these symptoms are also there. Productive cough is also there in pulsatilla, as you can see. But then I can differentiate between pulsatilla and phosphorus from this graph. Like pulsatilla has a more than, it is almost 4, a more than 3 likelihood ratio for productive cough, but it has less than 1 for dyspnea. That means productive cough is an indication for pulsatilla, but if it is dyspnea, it is not an indication for pulsatilla. So this is a differentiating feature between phosphorus and pulsatilla. But here there is one more thing which needs to be taken care of. If I see this line, here we can see that hypersulf is going far beyond 6. It was actually the likelihood ratio of hyper was more than 7, which I'll be discussing later. Now in this graph, as we move further, we saw that there are certain disparities. Like in this, loss of smell and taste, magnesia muriaticum. See the graph? It is way beyond 6. It was somewhere around 12. Similarly, if I see other remedies, thirst decreased, pulsatilla, way beyond 6. Running nose, again pulsatilla, way beyond 6. So this, and then there were blanks also. These blanks actually indicate 2 things. Either that symptom was not present in that particular medicine population. Like here you can see after gelsemium, there is nothing for hyper. That means either hyper, there was no case of loss of smell and taste in hyper population, or that symptom was not checked in hyper population. Similarly, here also there is a gap, and so on. In this graph also, we can see that we have outliner values for symptom chill, symptom anxiety, sleep disturbed, and there are plenty of blanks in between. And these blanks, if you see, are mostly for the lesser known remedies, like the lesser used remedies, like say belladonna, magnesia muriaticum, and hyper. The maximum number of blanks which we got were for magnesia mur and hypersulf. This was the reason that after doing the first analysis of likelihood ratio and after plotting it, we thought that there is something wrong with this data and we need to further explore why is it so. Therefore, afterwards, we calculated the variance. And when we did so, we were amazed. See, in this particular symptom, loss of taste and smell, the variance is very high, 15.94. This is particularly because among all these 9 remedies, magnesia muriaticum has a very high outliner value of 12.91. Similarly, if I look at productive cough, here also a very big outliner value, 7.47, which I had showed you in the graph also. Here, if I look for the symptom chill, again a very high variance, 29.3. Why? The reason being that all other values are below 3, you can see, but this likelihood ratio of hyper for symptom chill is 17.28, which is too high. So we calculated the variance for a particular remedy also for all the symptoms. And this is what we found. HEPA, the variance is very high, 14.05, mainly because of two symptoms, that is chill and productive cough, in which the likelihood ratio was too high, as well as for magnesium mu. Here also the variance is very high, 7.72. All others are within the normal range. So what we got, we actually then further looked into it and found that for these remedies, these particular symptoms have higher than 5 likelihood ratio. For arsenic, it was anxiety, all the ones in red. For brina, it was constipation. For HEPA, it was chill and productive cough. Magnesium muriaticum, it was loss of taste and smell. No other symptom was even checked for this particular medicine. Then for phosphorus, it was sleep disturbed. Pulsatilla, thirstlessness and running nose. For nux vomica, it was all abdominal symptoms, flatulence, diarrhea, abdominal pain, and just one symptom of nose block. This confirmed that we had bias in our data. This bias was probably confirmation bias, which led to lowering of the symptom threshold. Then there was keynote prescribing, and insufficient checking of symptoms was also identified as one of the important sources of bias. Confirmation bias is the bias when a physician tries to match his preferred medicine, which he easily recognizes during the process of consultation. While a patient is coming to us, initially when we ask few symptoms, then we tend to form a drug picture. Okay, this patient looks more like pulsatilla, or this patient looks more like phosphorus. And then we lower our threshold for that particular symptom. And even if that symptom is of low intensity, we tend to include it in our totality of patient and prescribe accordingly. So that leads to confirmation bias as well as lowering of our threshold. Then in this case, we also found that there was keynote prescribing, but probably magnesium muriaticum and HEPA self were prescribed only based on 1 or 2 symptoms in this case. When we analyzed the data, we found that the overall prevalence of loss of smell and taste is just 10.2%. While for magnesium muriaticum population, it was higher than 97%. And it was just one doctor who had frequently prescribed this remedy. And there was insufficient checking of symptoms also. He didn't bother to check rest of the symptoms. So our take-home message is that careful identification of bias is necessary. During the first consultation in the prognostic factor study, a predefined set of symptoms should be checked apart from the contextual symptoms of the patient, even if the practitioner has already recognized the indicated medicine. In this study, we had already circulated the Excel sheet to the physicians at the start of the treatment itself. But somehow or the other, due to paucity of time or over enthusiasm, some of the physicians, they missed those symptoms. So invariably, that all reflected in the statistical analysis. And unfortunately, we could not use this study for planning a RCT. What we suggest is that remedial steps like training of our doctors, regular monitoring of data, checking of all predefined symptoms, and a multi-centric data collection will help us to mitigate the biases. This is another study. Actually, it was after this study, we realized that whatever problems we are facing, is it just a phenomena with us, or is it a phenomena worldwide? So we try to understand whether our results can be generalized or not. In that case, what we did was, we plan to assess the consistency and possible flaws of 2 data collection projects on COVID-19, which had been done in different settings, but had comparable outcomes. So what we did is, we did 2 comparisons in this study. The first comparison was prognostic factor data collection done by Liga, LMHI, in May 2020, that was during the first wave, containing 161 cases, was compared with an updated PFR data collection by LMHI itself, done in February 2021. This February, up to February, 541 cases were already collected by about 100 doctors across the globe, because LMHI is a very big organization. Then the second comparison was that the updated LMHI database, that is the one containing 541 cases, was compared with the data collection which was done by our doctors in Delhi which I have recently discussed with you, which contained 1,445 cases. The reason why we compared these two only and we couldn't compare others was because they both had a similar methodology. They used prognostic factor research model for analysis, and the assessment and comparable outcomes were there. So the study was done. Likelihood ratio of 18 symptoms for 3 medicines were compared between the early and the updated LMHI database, the one which was there in May and the one in February 2021. Here, 3 medicines were compared: arsenic, bromine, and gelsemium. Differences that resulted in conflicting outcomes. That is an indication in one database and a contraindication of the same medicine in the other database was said to be conflicting, and that was examined. And if it was found, we try to understand the possible reasons for it. In this particular comparison, the first comparison, there was only a single outcome in the updated LMHI database that was conflicted with the previous database. And that was in the symptom throat pain for gelsemium. In May 2020, this symptom was an indication for gelsemium, while in February 2021, it became a contraindication. This could be because of statistical variation. The reason why I'm saying is, in May data, when we did the gelsemium analysis, we found that likelihood ratio was 1.78 with a confidence interval in a range of 1.79 to 3. And when we did it in February, the likelihood ratio was less than 1. It was somewhere around 0.79, but the CI was in between. So we thought probably there was some statistical variation. That is the reason it might have been. In the other comparison, again, the conflicting outcome was the same, an indication in one and a contraindication in the other. Here we compared 12 symptoms for 6 medicines: arsenic, bromine, gelsemium, nux vomica, phosphorus, and pulsatilla. In the resulting 72 comparisons, we found that 6 conflicting outcomes were there. That is almost 8.3%. These outcomes were related to actually 5 symptoms. That is dyspnea, headache, chill, sore throat, and myalgia. This is the graphical presentation. As you can see, in LMHI database, the one in blue, arsenic is a contraindication if a symptom dyspnea is present. But for the Indian counterpart, yeah. May I continue?
Yes, of course.
Okay. In arsenic,
go ahead.
Thank you, sir. In arsenic, dyspnea symptom is an indication for Indian database, but a counterindication for LMHI database. If I move ahead for nux vomica, headache was an indication, but a contraindication for us. For the same symptom, chill, pulsatilla is an indication for Indian database, but a counterindication. And gelsemium, again for the symptom chill, the LR is too high, 3.1, while here we get just 0.42 for the Indian database. Sore throat and nux vomica are a combination for the LMHI database, not for the Indian one. This was also probably because the symptom was missed by us. And the other, when you see myalgia, gelsemium comes at a lower level, 0.94, while in the Indian database, it was too high. So we gathered that when we compare these two different databases, there is a considerable consistency between the two with only 8.3 conflicting outcomes. These conflicting outcomes can be easily managed. That was the crux of this study. Statistical variation, we cannot do anything much about it, but other things like keynote prescribing leading to insufficient checking of symptoms, which we saw in our cases of nux vomica as well as in cases of gelsemium. And other thing which we find as a lacuna is that number of cases in the LMHI database were less, but the collection was done by more than 100 doctors. So invariably, the biases level becomes less because the more doctors there are, the biases gets mitigated. But in the Indian database, since the number of doctors were low, so the biases were probably more and hence the conflicting rate of 8.3. The consistency may be interpreted as showing a strong overall consensus between homeopathic practitioners worldwide, which is a positive sign and which we'll actually look forward to so that we collaborate with others as well, but with some variation of consensus between small groups of practitioners. So we also, after this study, we also, further try to make our practitioners understand that they have to give more time to their patients. Instead of just collecting data and thinking about the quantity, it is better to think about the quality and give better results in that manner. This was a lesson for us. So when we had our second wave, which we had this year, we did another study. This year, the second wave in India was actually very, it was like a tsunami for us. As you can see from this diagram, in the first wave, we reached the peak in 110 days. But in the second wave, we already crossed that peak in 62 days. And as we all know that the Delta variant was actually declared as a VOC, variant of concern, by WHO. In this second wave, we found certain new symptoms also, along with those which were already there. The diarrhea cases were more. We even got certain symptoms of conjunctivitis, skin rash. And I'll just touch on it because this study is already under publication. The objectives were to clinically find useful homeopathic remedies in the second wave and determine their characteristic indications using prognostic factor research by calculating likelihood ratio. This was again a multi-centric trial, an open label trial, and this was done at a bigger level. We had 41 doctors actually participating in this, and we were able to collect a good number of cases within a period of 3 months, from March 2021 to May 2021. We actually collected 769 patients, mild to moderate, all on add-on therapy, along with the modern science, along with the allopathic treatment. Out of this, we excluded 255 cases because we had defined a selection criteria. Those cases which didn't meet that selection criteria were excluded, and 514 cases were selected for analysis. These are the medicines prescribed. Total, we had prescribed 39 medicines in different patients, out of which the most prescribed medicine was Brineia, followed by arsenic, pulsatilla, belladonna, gelsemium. This time we even got cases of phosphorus, Merck, and Rustox. Phosphorus cases we had in last wave also, but they were very few. These were some of the prescribing indications which we could elicit in our LR value study. For arsenic, it was anxiety, sneezing, increased thirst, diarrhea, and restlessness. Belladonna we saw worked better in cases of headache. Conjunctivitis cases we saw improved better with belladonna. Then fever, throat pain. Brineia, it was more of constipation, dry cough, dryness of mouth and throat, cough again, and then conjunctivitis. Conjunctivitis was seen in Brineia also, but in belladonna, the likelihood ratio was 3.42, and in Brineia, it was somewhere around 2.1. In gelsemium, we had decreased thirst, headache, myalgia, fatigue, and coryza. Hyper cases, we had chill, productive cough, nose blocked, sore throat. This time, we didn't have much of outliner symptoms also. Merck, which was a new remedy for us, came up this time for fever, perspiration, dyspnea, pneumonia, and fatigue. This time we had cases of pneumonia as well in the second wave. And phosphorus also worked very well for pneumonia cases. The likelihood ratio for phosphorus was somewhere around 3.7 and Merck was 2.3 or 2.34. And phosphorus was also indicated for flatulence, cough, and chest discomfort. Pulsatilla, it was thirst decreased. Sadness was a new symptom for us, which was not there in the first wave. And productive cough was there, loss of taste and smell. This was a persistent symptom which we got even in the first wave. And this was in the second wave also, we got a good likelihood ratio for this symptom. So this reiterated our belief that probably pulsatilla works better for this particular symptom. And the last symptom which we saw was appetite decreased. Rustox, we found in cases it helps which have headache, restlessness, sleeplessness, and nausea. So the prescribing indications of 9 most frequently used homeopathic medicines, which I've already told you, that is Brineia, arsenic, pulsatilla, belladonna, gels, hyper, sulf, phosphorus, rustox, and Merxol were identified during this particular study. And we hope that this will improve the accuracy of future homeopathic prescribing symptoms in COVID-19. So the take-home message and the way forward is that the prognostic factor research in observational studies is an important technique for the analysis of cohorts of real-world care settings. Such studies are actually very important because they provide a prior experience, and a well-designed RCT requires us to have a good prior experience and outcome documentation. It also helps us to build a consensus among homeopathic practitioners worldwide, considering that many countries are still being affected by this enigmatic virus, and there seems to be a little respite from this pandemic in near future. These are my co-authors whom I like to thank, and I'll like to especially thank Dr. Lex Ritton for helping us in between and becoming a mentor for us for the particular analysis as well. Thank you for your patient listening. Thank you.
Thank you, Dr. Anjali, for this wonderful presentation. And it's an excellent study. Thank you. For me, it shows again not to prescribe with the key symptoms and take the case with total symptoms, and not prescribing the remedy with prejudgment. Thank you. It was very nice to hear this. And if Gustavo, if you want to comment.
Thank you, ma'am.
Sí, bueno, esto tiene la... Do you have the translation open?
No, sir. No, sir.
Okay. This confirmed that that Hahnemann claimed in his organon about the bias of confirmation. Hahnemann said, observer free of prejudice.
Yes.
So he anticipated this problem in the mind of the homeopath. Just one thing of terminology about counterindication. I think that I don't know if it's the proper term, counterindication, or less probability. I don't know. Please tell me.
Sir, you are actually very right that we thought at that moment of time that it is probably a, should I repeat, sir? At that moment of time, we actually thought that it is probably a contraindication. But later on now, like we did another study, so we found that probably the number of cases were too less for us to say that it is an absolute contraindication. It was that at that relative time period, when we compared the two databases, we just wanted to highlight not that it is a contraindication, but yes, probably this medicine didn't work for this case in these type of data set, and for this case in these type of data set. Now, as we are also learning from experience, and so many things are coming up. So now we understand that as there is more influx of cases from different doctors, so those symptoms which at that moment of time seemed not to be indicating that medicine, perhaps are not that adverse contraindication.
Yes.
It improves with more and more data.
Yes, because my opinion is that one symptom doesn't exclude a remedy. Doesn't exclude a remedy, because this could be another bias.
Yeah. So we are actually working on another paper. In that also, we are working on, we have found bias in certain things. Even after doing the complete analysis, while we were at the fagging end, that paper is also under publication right now. Fagging end, then we realized that certain cases of Merck, which we thought were right at that moment of time, now we understand that probably that was also a particular mindset of few physicians, and they were vigorously promoting that it is all dyspnea cases and all cases with chest discomfort are Merck. But when we got more cases of phosphorus, arsenic, bryonia coming in from other sites, then we realized that it is very difficult to say that just one remedy covers everything, and to promote just one remedy as genus epidemicus. this, even in the last session, one of our esteemed speakers also said that genus epidemicus can change. Like in China cases, they had seen
Okay.
that more than one medicine, 2 or 3 medicines maybe.
Thanks, Dr. Migliani, and I remind all the attendees that the collection of cases of LMHI is in our web page. In the web page, you are going to find the collecting cases that one group, the Lexington group, made in COVID pandemic. Thanks, Dr. Magliani. Please, Dr. Gorkam and Levent, go ahead with the next
With
presentation.
all due respect to the chair, I would request honorable doctors to please have a discussion for next 2-3 minutes, as there is a problem with the Chinese interpretation. So I would request the moderators if they could please reintroduce the session or tell our audience more about the session so that we can get the Chinese interpretation fixed and then start with the next session. That would be great.
Okay, okay. Thank you, Dr. Migliani, for your previous presentation and your.
Excuse me, Levent, maybe I interpret Dr. Do you want us to follow with the debate?
Yeah. No, we will continue.
Yes. Actually, you can have a discussion for next 2-3 minutes until we get the problem with the interpretation fixed. We actually have got a problem with the interpretation in the Chinese section. I would request if anybody can have a discussion here, because there are 2 insightful sessions and there might be a lot of questions.
Okay.
Please, Andre.
Yes.
Raise your hand.
You have touched a subject of contraindication. Actually, Hahnemann addressed this subject very clearly in many, many instances, and the most clearly place where he touched this point is the footnote to paragraph 213, where he says a remedy will never or ever cure if it does not have these symptoms, like sine qua non. So there are many sine qua non, and that was used very successfully in practice. In other words, if you don't have a certain symptom, you cannot prescribe that remedy, or if you have a certain symptom, you cannot prescribe that remedy. And that was emphasized a lot by the American School of Homeopathy, very successfully in practice, because they were able to differentiate a case because a symptom was missing or because there was a certain symptom present. So I think it's a very big subject, and it's not it's not like never. It's just you have to be a very good prescriber sometimes to go against a certain symptom of a patient to prescribe a remedy that would have a sine qua non, for instance. So that's a big important point clinically, and very useful clinically, because clinically you can do a differentiation of remedies just from the sine qua non. You may have like 6 remedies at the end of your study, and you can eliminate 5 right away because some symptom have certain symptom that the other ones that should be present in the patient, for instance. I will touch at this subject in my presentation 2 sessions from now.
Yes, sir. I also believe
Thanks, Dr. Saine.
Okay, is there anyone want to say something about?
May I?
Yes, please.
Yes, sir. I also totally agree with you. That is why we say that homeopathy is ahead of its time. Dr. Hahnemann at that time, centuries ago, predicted the same words like unprejudiced observer and how important these symptoms are for us. And now we are actually just reiterating whatever he had already told us. So I believe that homeopathy is a wonderful science and there is so much more to learn. Thank you.
Thank you. Thank you so much, doctors, for all your patience. I would now pass the mic to the moderators. The virtual dais is all yours. Please continue. Thank you.
Okay, we are continuing now with Dr. David Liley from South Africa. He has practiced homeopathy for 55 years. In 1995, he founded the South African Faculty of homeopathy to provide homeopathic education and for medical doctors. And he acted as a dean until 2012. Since 2007, David has conducted a small select practice in Cape Town, South Africa. He has some publications also, and we can start with his pre-recorded video. Okay, now we can start. Please. Now we are waiting for his video.
I think technical persons
Yes.
has made it.
You can
Yeah.
go on with Andres's presentation.
Yeah, why not? We can change, and Andre can start. And please, Gökhan, you can talk about his homeopathic.
Ah,
Are we ready for me?
No, no.
do you want me to present you?
Oh, sure.
Yes. Now we move along to our third session to listen to a very interesting presentation of Andresen. Dr. Andresen graduated in 1982 from the National College of Naturopathic Medicine in Portland, Oregon, with the objective to specialize in homeopathy. The main thrust of Dr. Sen's clinical work is the treatment of patients with serious pathology. He showed over the years that it is relatively easy to deal with patients with the most serious infections, immune and mental diseases. He has recently pushed the limits of the homeopathy by documenting phenomenal results in patients with Parkinson's disease, genetic diseases such as cystic fibrosis and retinitis pigmentosa, Alzheimer's disease, acromegaly, and stage 3 and 4 cancer. Moving along to our session, please welcome Dr. Andresen, who will be speaking to us on cumulative experience on the prevention of COVID-19 and the treatment of the COVID-19 patient. Welcome.
Thank you for the invitation to speak before the world homeopathic community. The presentation that I will make today is very long, and I will just skip over the main passages, but I will make the text available for everyone. So first of all, sometimes you hear that COVID is a benign disease, so it's not true. COVID can manifest itself, of course, with being benign, but it can be also associated with severe respiratory distress and a number of very serious complications, and must therefore be addressed very seriously by a homeopath. Many patients who were in great physical shape, when they fell sick to COVID, they would report that they've never felt so sick in their life, as if this virus was completely new to our genome. So this presentation was prepared by clinicians in the field from around the world, and is addressed to other clinicians in the field who could benefit from the accumulation of very valuable observation. I want here to thank all my colleagues who have taken the time to write reports and send them to me in order to make this presentation possible. Unfortunately, I was not able to integrate all the observation I received, but I will try to do it maybe in later days. Some report I got even last night. This presentation is also meant to be a testimony to future generation of homeopaths, as it was with the paper Dr. William Dewey of the University of Michigan published in 1921 in the Journal of the American Institute of Homeopathy to recount the outcome of homeopathy during the Spanish flu that was entitled Homeopathy in Influenza, a chorus of 50 in harmony, 50 physicians he met. And here too, we have about over 50 that have reported. I have the testimony of about over 50 physicians. So I will present in this review the cumulative experience of a great number of colleagues who sent me their observation, which has many advantages, including obtaining a broader overview of the outcome of homeopathy in the epidemic. So not just one place, just one physician, but overall a better view. And to enhance the learning of each other's experience. Also, the reporting of rare and unusual observation whose knowledge could have greater implication for our community in general. And finally, the comparison of results with the use of different protocol in different population. So I will essentially touch 2 points: the prevention and the treatment, the prevention of COVID-19 and the treatment of the COVID-19 patients. The prevention of COVID-19 has so far been a great success with homeoprophylaxis. Despite the many different geographical area and the different SARS-CoV-2 variants, Brownia has been overall the main prescribed remedy in the sick, about 60 to 70% in my patient in the first stage of the disease. But in some colleagues, they report 95% of their cases are treated with Brownia. So when you have such a high number of people responding to Brownia, it points to Brownia to be used for prophylactic purposes. So most of my colleagues have used mostly or uniquely actually Brownia for prevention since March 2020. And even with the change of variant, the Brownia was really changed, except one time I mentioned here when in the northeast of the United States, after the arrival of the Delta, we had the cluster of cases, 8 cases that were very severe case of COVID, and they all responded to Ipecac. And so therefore, even though Ipecac is a later stage remedy, and you're supposed to give the first stage remedy, I did distribute in that area Ipecac for a short period of time, about 1 or 2 months. Now they're back on Brownia for prevention. So Brownia was chosen very early in the pandemic as 3 or 4 cases of my patient who present with unusually severe flu-like symptom in December 19. So pay attention to this, December 19, because we're going to come back to that. And in January 20, they respond to Brownia. In hindsight, it is possible that these cases already were cases of COVID-19, early case, because many physicians and there's many report that there were cases in the population before, in the general population in the world before December sometime in the fall of 2019. So none of the one who took Ipecac in this small area got COVID, but this is no proof of efficacy because we don't have a comparative group. However, here is an interesting observation report by Betsy Bevan from Massachusetts, Northeastern United States. I says, I found Brownia helpful in over 85 to 9% of the case I dealt with all year, maybe 10% needed another remedy. So again, that high percentage of people needing the remedy, pointing to a genius epidemicus. Not all my colleagues abide to the same pathology for the prevention of COVID-19, but here is how I have recommended my patients who are not hypersensitive to take Brownia, which is 1 dose of the 200 or 200D, because we use the Dunham potency in our clinic, but not everybody has access to that. So once a week to every 6 weeks, depending on the degree exposure of the person. And this is continued for a period of 6 to 12 months, depending on the number of doses taken. After 6 to 12 months, I recommend my patient to switch to Brownia 1M, which is taken in a similar manner for about 12 months, for another 12 months. After 1 year on Brownia 1M, they were encouraged to move to 10M potency every 4 to 6 weeks for another year. If there would be a clear exposure to someone who is coughing, or with a person who has been diagnosed or will be diagnosed, or who were later diagnosed with active COVID-19, I encourage my patient to take the prophylactic remedy in the potency they were already taking twice a day for 2 or 3 days. For the ones who are flying and mix with other in airports and large group in closed rooms like church and weddings and so on, we recommend that they take extra dose of Brownia in the potency they were already taking before and after each flight, and sometime twice the next day, especially during the time of heightened number of cases in the population. For hypersensitive patients, I want to point out that they can still be protected, but the potency has to be adapted appropriately to their sensitivity. For instance, I have an extremely sensitive patient who rarely leaves her house, but whose husband mixes with many others every working day of the week. She has been taking Brownia 6C, very diluted, with a toothpick on the skin once every 6 to 8 weeks. She was exposed to her husband who developed COVID-19, but never developed it. However, she reported that since March 2020, she has taken Brownia 6C, as indicated above, 5 or 6 times at the very beginning of when she experienced flu-like symptoms, and every time it stopped the disease process at once. We also told patients to take Brownia in the potency, like in this case, they were already taking for prevention every hour, for 3 doses at any time they would experience flu-like symptoms, such as a combination of sore throat, chills, fever, body ache, unusual fatigue, loss of taste or smell, difficulty breathing, coughing. Many people have followed this instruction exactly, but very few have also not recovered. But very few have not recovered at once. So once they did the protocol of feeling the flu-like symptom, very, very few did not recover quickly. The patient are told to repeat again 1 dose per hour for 3 doses of Brownia as soon as they would experience a relapse of the flu-like symptom. If the symptom would keep relapsing, they were told to begin the next potency of Brownia and to take in the same fashion, and as a rule, that would finish the case. However, if at any time they are not responding to Brownia, they're instructed to call us right away. And I don't think I had any case of person taking Brownia properly that actually called us to say they did develop COVID. Usually it's when they didn't take Brownia properly. So I mentioned here. On the other hand, many have taken the remedy very irregularly, mainly when there was a clear encounter with a COVID patient. Did they take the Brownia, or when they experience flu-like symptom, which may also be a good strategy. As for most, with the exception of the severely immunocompromised person and very old and frail people, pregnant women, and people with serious comorbidity, it is fine to get COVID in order to develop long-term immunity. Especially if you're under the not only if you're under the care of a skilled homeopathic physician, of course. By taking Brownia in such a way that is as needed when they feel they were highly exposed or at the beginning of symptom, rather than to follow a more regimental prophylactic protocol, they provide greater opportunity for the organism to develop natural immunity. The results so far obtained in the prevention of COVID-19 with Brownia have met our expectation, as we should expect when people are taking an homeopathic remedy for prevention that is corresponding to the first case of the disease in about 65 to 95% of the case. that is that's so far been observed in this pandemic, 65 to 95%. That's according to different physicians reporting in different places. The degree of effectiveness of Brania is so far comparable to the one obtained with belladonna for the prevention of scarlet fever, because here we have a very, very clear study. In similarly, in over 100 people who were similarly exposed to scarlet fever, only 1% of the one who took belladonna preventively contracted the disease, while 60% of the one who didn't take the belladonna fell sick. So this is extraordinarily statistically significant. For the one interested in this subject, which is very interesting, I'll be talking tomorrow during this colloquium at 1:45 or 13:45 Central European time in all three, which is the result of a systematic review that I recently completed on the scientific evidence of the effectiveness and efficacy of belladonna to prevent scarlet fever. However, despite the best prevention measure with homeopathy, there will always be some case that will fall sick during epidemics, which is also the case in the current COVID-19 pandemic. And we ask patients not to delay calling their practitioner, as COVID-19 can degenerate quickly in some individuals, and it is relatively easy to treat COVID-19 patients with homeopathy, especially in the early stage, and as long as patients have really readily access to the most used remedy. So this is very important. It is for this reason that we ask our patients who are from all over the world to have in their possession or have readily access to the following homeopathic remedy, which should also be equally useful in the event of an upcoming influenza epidemic. The influenza epidemic is predicted to be severe this year, so the same remedy would be also used. I recall calling a patient in a hospital in India in June who was on a respirator. Her husband was the physician, and I told him the remedy to take, and he called me the next day. He says, I cannot find the remedy. And he says, I say, why? He says, all the homeopathic shops are closed. I say, why? Because of COVID. So here in the United States, the situation is in North America, the situation is very complex. Also in France, I talked to a patient in France this week. The access to high potency, like 200 and above, is almost impossible in France. And in the United States, it's getting more and more difficult to get remedies, because since COVID, the supply chains have been broken. So we ask them now to have readily access, because if you fall sick on a Friday night, by Tuesday, if you order your remedy, if you can order it, if you get it by Tuesday, it could be very too late. So these is a list of the remedy and the potency we recommend people to have. Another advantage of homeoprophylaxis, aside from the prevention of developing the disease, when the remedy used for prevention is not omnimogeneous epidemics, that means 100% effective, is the decrease in the severity and mortality from the epidemic disease. I collect the experience of several colleagues who share their observation they have so far made in this pandemic with the use of Brania to prevent COVID-19, as with few exceptions, the great majority of colleagues have used Brania as a prophylactic remedy around the globe. So here is the people who took Brania preventively. Here, the second column is the people that were clearly exposed. We don't know because we didn't ask that question, but some physician knew how many were clearly exposed, how many of these got COVID, and how many were spared of COVID, how many got COVID, how many got severe COVID, and how many died. So here we have, if we look at the total at the bottom here, we have 1,600 person that took Brania. 41 were clearly exposed, and now it's the person in the house that had COVID or care for people with COVID and were clearly exposed to people with COVID. 41 were protected. Of the 1,681, 104 fell sick. Only 10 got severe COVID. That means were hospitalized, and on 0, there was no death. The fact that out of 1,681 patients, only 104 or 6% fell sick can only be suggestive of the effectiveness of Brownia to prevent COVID, as we don't know the degree of exposure and other variable, and we have no comparative group. When we talk about belladonna, before belladonna during the early part of the 19th century was almost 100% transmissible. In other words, if scarlet fever would approach a village, almost all the children that never had scarlet fever would get scarlet fever. So extremely contagious and also extremely virulent. So the fact that here we do have results similar to the one of belladonna. Belladonna, the result were about 98% without comparative group. But when we look at comparative group, the protective rate was 99%. However, the fact that 41 out of 41 persons who were closely exposed to COVID-19 patients, such as sleeping in the same room and caring for them 24/7, is more suggestive of the effectiveness of Brownia. For instance, I had a patient that in her mid-60s, she was the only one in her family, in her household of 3, all in the mid-60s, that took Brownia. Her brother got COVID first. He transmitted the virus to her brother-in-law, to his brother-in-law, who became very sick also. Both had refused to take Brownia preventively. Both, the husband was deadly sick on his bed. That's what he thought. And his wife was able to convince him to take Brownia when he was extremely, like when he felt he was dying, and he recovered quickly, and the brother-in-law decided to take it. But that's interesting. She never got any symptom of COVID, and she was the only one that took the Brownia. And that's very, very typical of a remedy. It's a sign, a very good sign of that the remedy is very protective. And the husband insists to talk to me the following day on the phone, and he says he felt that Brownia had saved his life because he felt so sick, the poor man. Same thing here. We have other similar experience reported by other colleagues of only the people that took Brownia that were protected in the same household. In the Indian study that was published earlier this year, where Brownia was given twice a day for 3 days, and each person was checked on the 15 and 30 day only, so it's not very long. The odd ratio to prevent COVID versus placebo was statistically significant only for Brownia. They had other groups with arsenicum album and gelsemium and combination remedy. A colleague from Edmonton reported the same type of, well, here it is, you can read it. I had one late stage 4 cancer patient who developed COVID-19 symptom on August 12, 2021, who was not taking Brownia, was briefly admitted to the emergency room. She was diagnosed after having tested positive and was told until she started turning blue to stay at home. She responded immediately and quickly to carborneum oxygentum in ascending potency. Within 1 week, she was completely healed. As of this writing, she has no longer term sequelae for the disease. Her entire family, 4 people, were prescribed Brownia prophylactically, and none developed any symptom despite living with her and being in contact with her. Dr. Salzman from New York City report the same thing, or from New York State report the same thing, same type of observation. Here we have a patient from Ohio who had contacted about 200 relatives, friends, and patients and their family to take Brownia. Out of these 200 people they contact, over 125 accepted to take Brownia on a regular basis. And he wrote, as far as I know, none of the people I informed about use of Brownia to prevent infection with COVID-19 have been infected, none. So that's, and he keeps in contact with them by phone and by email. So that's remarkable, especially that was started in March, about March or late March 2020. So that's about 9 months before the vaccine came in. I have not made any sort of official research on it, but I am in contact with almost all the people I notified. In fact, there were 8 people out of 20 to whom I spoke of Brownia decide not to take the Brownia and have been infected with the virus. Unfortunately, one of them, my brother-in-law, a Supreme Court of Ohio, alternate justice, who passed away after 2 months of being in a coma from the virus. So that is the gist of my awareness of my friends and patients to whom I spoke of Brownia. One thing I don't know is whether or not those who were taking Brownia are not and are now immunized with the vaccine and are still taking Brownia. My advice has been to continue to take the Brownia if you have been vaccinated. So this is a similar experience in Spain and in New Mexico. The similar experience of the prevention of COVID with Brownia. Here is an interesting observation. It's in a 98-year-old woman that fell sick to COVID and was taking a nosode for prevention, but was still fell sick, and she responded to Brownia as soon as it was given to her. An interesting observation made by my son in New Mexico. He reported that 2 people that were exposed to a group of patients that had COVID, both people had a bit of symptom of COVID, but very, very mild, like sniffle, but they both test negative to COVID, but they were taking Brownia. So it's possible that the virus don't live very long in a person that takes Brownia, and the test would be negative. So this is only observation in 2 people. Here we have a nurse from England who report, homeopath from England, sorry, who report 3 nurses who were in contact with patients with COVID, 2 of them anyway, and none got sick, and none got vaccinated, and they were all taking the Brownia. So here is other experience from Germany. Okay, so what is the overall assessment of the effectiveness of Brownia to prevent COVID-19? The number given above in the table are a very small sample associated with loose data collection from busy clinicians in different populations in which Brownia was taken irregularly and with different protocol. Even though there are so many variables that can affect results, such as age, health status, degree of exposure, and compliance of taking the Brownia properly, that we can clinically depict trends, which has very well served homeopathy so far in the last 200 years, we could say, and the people that benefit from homeopathy, and confirm that we have already known what we have already known about homeoprophylaxis for the last 2 centuries. The history of, including the history of homeoprophylaxis has already been partially researched in an upcoming book, The Weight of Evidence, and above all, the numbers recall similar success as the one reported during the 1918-19 Spanish flu epidemic. And also the result that was just recently found in a systematic review on belladonna. It really gives a lot of weight to the scientific evidence of homeopathy for the prevention of an epidemic disease. And the finding found in the RCT that I presented a bit earlier, that I found Brownia to be the better remedy than placebo. But even better, it is a trial report by Dr. Pradip Kumar Gupta of Agra, who administered with his team and the participation of 20 non-governmental organizations 2 doses of Brownia to 70,000 people between May 16, 2020 until July 2020 in 4 different areas of India out of 60,000 people. And these were mostly working people, working force, who got the Brownia. None became infected after the first 9 weeks. So this is, again, we don't have a comparative group, but its indication that trends that we have seen before in the past in homeopathy that indicate that, yes, the homeoprophylaxis works very well. The bottom line is this: homeoprophylaxis is very safe, efficacious, with a better protocol, of course, cost-effective, quick to deploy, and simple to apply. Okay, let's go now to the treatment of the COVID patient. Before seeing our first case of COVID-19, I was very confident to be able to deal with this new epidemic with flying color because, and part of the weight of evidence, I showed that the death rate in pneumonia with Hahnemannian homeopathy is minimal as compared to current conventional care, all type of pneumonia and all group age. In 2018, I present 4 cases of 4 very elderly people, like 92, 95, 99, and 100 years old, that were moribund, like they were on their deathbed, and they were waiting for death, and they all recover under homeopathy. So if these people can recover under homeopathy, we should have success. Even before this presentation, I had presented a case that with pneumonia, and where I said nobody should die of pneumonia as long as homeopathic treatment is properly administered. And I'd shown that people with immune deficiency and comatose patient with cryptical meningitis, people with pneumonia with advanced lung cancer, pneumonia in people with advanced heart and kidney failure, a supposedly incurable chronic pulmonary aspergillosis, or a 2-year-old boy in his last breath with viral pneumonia, they all respond well. They were all unresponsive. He was irresponsive, but they all respond well to homeopathy, and they all recover, as if there's no exception, as long as there's a good homeopath with the remedy at the bedside. Because we're dealing with a law of nature. It's so simple. It just needs to be applied properly. In 2013, in a discussion with skeptic Stephen Novella from Yale University, I reported that Dr. Royal Hayes had treated 900 cases of pneumonia during the Spanish flu, of which 69 were of the malignant type, and he had lost only 2 cases. So that's remarkable. We should therefore expect the same type of success in the treatment of the severe COVID patient. And this has now been clearly confirmed, even in the most severe case with the worst comorbidity. Homeopathy has shown to dramatically help COVID-19 patient to a quick and steady return of health, regardless of the state of the acute sickness at the onset of homeopathic treatment. As soon as homeopathic treatment began, a good homeopathic treatment, of course, recovery begins. I already report in earlier presentation the treatment of hospitalized COVID-19 patient and of elderly dependent patient in the nursing home. So I will not touch this here. In a recent presentation before the American Institute of Homeopathy, October 16th, I present 2 extremely severe, I should say extremely severe case of COVID-19. The first one was a 72-year-old diabetic and overweight who was in a comatose, semi-delirious, semi-comatose state at home. He didn't want to go to the hospital, and we treated him. Our equipment was 2 phones, a computer, an oximeter, a thermometer, and a blood pressure cuff. That's our equipment. No high-tech oxygen or intensive care unit, just these. And the treatment was started on August 31st. Less than 4 weeks later, KD said, "It's the best I felt in 25 years."
With all due respect, sir, so extremely sorry for the interruption, but as we are running short of time, may I request you to please wrap up in the next minute?
How much time do I have?
The time is already up, sir.
Oh, because I don't see the time. Okay.
Extremely
okay,
sorry.
good. Pardon?
Extremely sorry for the interruption. I just request you to please wrap up in next 30 seconds.
Okay, very good. So I present a number of very serious cases from me and from the colleagues. Then I will just go to the bottom line. I will let people to read it. I want to emphasize people. Let me see. I need to talk about this though. yeah, so there's few things that need to be talked about. There's cases. I would invite people to read the paper, but be aware that you need to read the Mathematica of Cabo. Let's see if we can find it. Yeah, so to read I will put this presentation on the website of the Kenyan Academy of Homeopathy. This is the address. I'll put the revised monograph of Carbonium oxygenatum with a new proving that was done in the spring of 2020. So that's very important for people to be aware of it and see all the implication of Carbonium oxygenatum, which is like kind of the chronic case of, not the chronic, but the advanced stage of COVID. So I would like to share this with all the community to be aware of this and look at all the cure that have followed with Carbonium oxygenatum. So I'm going to go then to the bottom line. Let me see. And so the bottom line is the prevention of COVID with homeoprophylaxis is very effective and safe. As a rule, it is easy to treat people with COVID-19, acute and chronic, as long as you're applying the fundamental principle of general homeopathy. And earlier in the presentation, I go every of these principles. Occasionally, a case may require more attention, and this has been the case if they are comorbidity as well as odd case after they are evolved of COVID. Beware that the picture may change of the remedy, so you may have to change your remedy, and continue to apply the remedy, to administer the remedy, even after the apparent sign of recovery and after what looks like full recovery. So I invite everybody to read this paper because there's a lot of gem, a lot of clinical pearls. And so I will end with a thank you to Dr. Samuel Hyman, because you have not lived in vain. Thank you for your attention.
Okay, now we can start with Dr. David Liley from South Africa. I had introduced him before Andre. Now we can start with his pre-recorded video. Andre, also there is a question for you in chat room. Maybe you can write your answer there, or if we have time at the end, you can answer, please.
Greetings from Cape Town, South Africa. It is a great pleasure for me to share this homeopathic time with you. I am David Lilly. I'm a fellow of the British Faculty of Homeopathy, and I have been active in the practice of homeopathy for 55 years. The title of my presentation is COVID-19, a positive COVID cosmic wave, a title prompted by my perception of current events. We are living in strange and precarious times that call upon us to exercise judgment based on our special, privileged homeopathic knowledge. If we hold true to the tenets of homeopathic science, this judgment will cause waves because it is inevitably at odds with the COVID-19 policy of conventional medicine and governments. Hahnemann was forever making waves. Though intended to further the progress of his beloved science, oftentimes he ended up rocking his own boat. This was particularly true of the greatest wave he ever caused, the one that followed the publication of chronic diseases, their peculiar nature, and their homeopathic cure. Making waves implies challenging established concepts. Possessing unique wisdom, homeopathy is ideally placed to create positive waves. However, positive external waves are best preceded by positive internal waves. And this was true of Hahnemann and his deliberations over chronic diseases. Prior to its publication, he removed himself from the political storms of Leipzig and found security and calm in Cothen, where he pondered long and hard, how disease first arose and why. For change and waves to be positive, wisdom is needed. Wisdom derived from the higher reality, standing behind and informing the objective reality that so attracts and misleads us. A wisdom as feminine and universal as logic is masculine and reductionist. Homeopathy is a multidimensional healing paradigm. It has access to hidden dimensions. Its imponderable potencies reveal the spirit in matter, an epiphany that evidences the sentience of the creation, and significantly at this time of planetary peril, the living, feeling, suffering sentience of Gaia, planet Earth. Homeopathic provings give access to a mythical dimension, the domain of the archetypes, the realm of myth and legend. Everyone possesses a personal myth, the story of their journey towards self-realization. Their ego-based disease is intrinsic to their myth and peoples it with heroes and heroines, demons and dragons. In the practice of depth homeopathy, the homeopathic archetype, selected through similarity, has the power to enter the shadow domain of the deep unconscious and release imprisoned energy. The healing event is a process of externalization, a movement of disturbed energy from within outwards, often imaged in archetypal dreams that portray the personal myth of the patient and prompt the way forward. The wisdom hidden within the dream must be interpreted. Its directive is most often cryptic, related in parable form. It needs unraveling. The homeopath must be a reader of dreams. As above, so below. Whereas a dream is a personal myth, a myth is a collective dream, a repository of encrypted wisdom relating to all humanity. Myths of all cultures impart wisdom and truth veiled in the imagery of fantasy. The homeopath must be a reader of myth. For insight into the strange times through which we are now passing, the myths of the Norsemen are most pertinent. In the Norse pantheon, Odin is the father of the gods, a god of many faces and many powers. Odin is revered as All-Father. Chief among his divine attributes are wisdom, magic, and healing, the three blessings of homeopathy. In his most numinous guise, Odin is a savior figure who on behalf of humanity sacrificed himself to gain spiritual wisdom. The divine aspects Odin retrieved are those we all lose into our shadow on incarnating. The soul's sense of deathlessness, its immortality, its oneness with the Creator, its oneness with the creation, its consciousness of its own infinite power, beauty, nobility, and perfection, and vital to living life efficiently and correctly, its basic trust. Trust that the constant and permanent qualities of the creation are love, truth, wisdom, and perfection, now, always, and everywhere. Trust that life is always positive, always loving, and regardless of circumstances, always happening for me and not to me. Trust that what is happening is always the best that can happen, and despite the worst adversity, tragedy, or disaster, unwavering trust that all is well. This is true of 2021 and true of COVID-19. These are powerful assertions of rune wisdom and surely the benchmark for making future waves. At a time of global pandemic, rune wisdom is indispensable for the application not only of good science, but best science. Loss of basic trust leaves us vulnerable and mortal, adrift in a mindless universe, subject to random events, seemingly devoid of positive direction and purpose, the very perception of today's frightened world. The consequence is soaring fear, frantic, psychotic escape responses, and inevitably, a destructive syphilitic outcome. Two creatures are inseparable from Odin, the wolf and the raven. They are All-Father's familiars and share his powers. However, as with all archetypes, wolf and raven have a dark side. They are shapeshifters and tricksters. And in 2021, they are out and about, spreading fake news, undermining basic trust. Aptly, a raven collective noun is a conspiracy of ravens. In the wild, wolf and raven hunt together. A splash of crimson against the intense white of the tundra alerts the ever-observant corvid, prompting its call to the wolf, providing a kill for the pack and rich pickings for the raven. Hence, red, the color of blood, speaks volumes to wolf and to raven. Both share the color's power and passionate symbolism. When man was a hunter-gatherer, human and wolf were rival apex predators. They were psychic siblings, Cain and Abel, destined to live out the biblical fratricidal myth, the extinction of the wolf in the wild, an act observed by raven, an act paralleled by man's desecration of nature, activities that have made Homo sapiens an infestation on the surface of planet Earth. Raven faithfully reports all these happenings to All-Father, Odin. Only homeopathy, through its provings, is privy to what Raven discloses to Odin. Raven serves not only as guardian to the British Crown at the Tower of London, Raven is guardian to Gaia. Two ravens are All-Father's constant companions. Hugin, the male, personifying intellect. Munin, the female, personifying intuition. The ravens are All-Father's eyes, ears, mind, and memory, his consciousness, sent out each dawn to quarter the earth to its remotest ends, returning at dusk with the day's tidings. Hence, Odin is known as the raven god. In their flight into the far reaches of the creation, Odin's ravens parallel the separation of the masculine and feminine principles within the psyche, a distancing that establishes the dominance of the essentially masculine ego self over the essentially feminine soul. This masculine shift underpins all psychopathology and all domestic and global conflict. This shift is the special province of Raven. The flight of the ravens also parallels the diaspora of a tribe away from its ancestral homeland, as of the Jews from Israel and the Irish from Ireland. Both tribes escaping intolerable circumstances in search of freedom. Raven has special affinity for both these tribes. Raven, more than any other archetype, can span generations and erase the miasmatic constitutional effects of ancestral suffering. In Greek mythology, Raven is sacred to Apollo, god of the sun. Apollo is revered as god of healing, but also as god of plagues, pestilence, and pandemics. Intuitively, the ancients experienced Apollo as both the cause and cure of disease. They perceived the healing power of illness, divined that cause and cure are entangled, and significantly, in the face of COVID-19, vested disease with positive redemptive purpose. The Apollo-Raven totem bond points to Raven's healing power and its relationship to plagues and pandemics. Indeed, COVID-19 could well be termed Corvid-19. Bringing Greek and Norse Raven myth together, the flight of Raven to the ends of the earth takes on another parallel, the dissemination of a coronavirus pandemic from a circumscribed epicenter to encompass the entire world. The source of the novel coronavirus is significant: a cave-dwelling bat, a creature possessing echolocation and a super-sensitive nervous system able to act as a sounding board for climate change, for environmental deterioration, and for the wayward frequencies that constantly bombard us. A creature possessing a unique biological peculiarity, the hosting of an inordinate number of coronavirus strains in its gut, far greater than any other animal researched, an arsenal of microorganisms awaiting Gaia's call to arms, each an arrow in the quiver of Artemis, Apollo's twin sister, who is most significantly the protectress of unspoiled wild places. The summons to arms came in 2019 when a critical level of planetary distress impinged on the cave bat's heightened sensitivity. Channeled through the bat to its resident coronavirus population, the discordant signal triggered mutations, singularly and appropriately hostile to man. And I emphasize, man. Hostile to the masculine principle, hostile to Cain, the plunderer of Mother Earth, not to the feminine principle. Following the red flag of the bat theme, bat, plutonium emerges from the shadows, the archetype that feels like a bat, sees bats, feels that they are hanging upside down like a bat, dreams of flying with wings and reports, I see sound waves from speakers. I feel them in my head like a bat. I feel I have echolocation like a bat. Plutonium is the last of the naturally occurring actinides, standing at the remote end of the periodic table, the furthermost outreach of matter. Metaphorically, the most distant point of Raven's flight away from All-Father, where the divergence between the masculine and feminine principles is at its greatest. A retiring archetype, found only in minute trace quantities in nature. The murderous intent of masculine aggression has transformed plutonium from a cloistered recluse into a weapon of mass destruction. In 1986, the Chernobyl nuclear disaster occurred. A circumscribed epicenter from which ionizing radiation spread diaspora-like, COVID-19-like, to the furthest reaches of the world. A plutonium happening, a Raven happening. Raven and plutonium are cosmically and esoterically bonded. The Northwest Amerindians revere the Raven as demiurge, a creator Raven, a being who in primitive times brought fire and light into the primordial darkness, an avian Prometheus, who stole celestial fire from heaven and gifted it to mankind, despite the stern decree of Zeus and Grey Eagle, the Greek and Amerindian godheads, that fire should be withheld from reckless mankind. When Prometheus appealed to Zeus on behalf of humankind, the great god cried out in rage, "Fire is not for them. Let them eat their meat raw." The fire Raven and Prometheus stole was not the flame of spiritual enlightenment, but the torch of the empirical intellect, which, inflated with hubris, tries to play God on earth, as it is now flagrantly doing. The consequences of Prometheus's gift of intellect are all about us: oceans choked with plastic, nervous systems fraught by high energy frequencies, genes disrupted by ionizing radiation, immune systems jarred by synthetic vaccines. The link between plutonium and Raven is confirmed by two SRP symptoms: desire to eat raw meat, the curse of Zeus; intense affinity for the color red, the color that warns, danger, and commands, stop. Homeopathic provings have given plutonium and Raven a voice in these matters. Plutonium speaks first. Despair for the future and for the world. Apocalyptic dreams, trying to save the world. Sensitive when hearing of cruelties, panic-stricken. Read the papers, the awful things happening in the world really get to me. I cry. At times my inner light was unreachable. Feelings of despair and desperation for myself and for the world. Delusion sees the earth exploding. Dreams, destruction of cities, destruction of thousands by atom bomb. Fear, fear of men, what they can do. Fear of the masculine principle. Fear of ecological disasters. Dreams warning of genetic mutations. Bat, double-bodied with 3 wings. Dogs with fins and fishtails. Dogs with multiple heads. People, half human, half animal. Giants, dwarfs, climbing a double helix staircase. And very disquieting, codes could identify each person by a code worn on the back. The threat of biometric passports, universal tagging, warning of brewing totalitarianism. Raven speaks through an apocalyptic dream. On the horizon, I saw something. It looked like an explosion, a cloud that grew black, huge, vertically into the atmosphere. And to my utmost horror, I began to see it mushroom out, the deadly shape of a huge nuclear blast. Then the sound and the heat hit us. The flesh on my legs was seared off my bones. The clarity, the lucidity, the intensity of Raven-released dreams is remarkable. On waking from the dream, a sense of impotent anger and despair about the savagery and utter stupidity of humans. Protection is a theme, the protection of animals and children and the planet. I was the only one doing the safeguarding. There is nothing I can do about what these idiots are doing to our planet. She feels like screaming. She feels so impotent, a rage feeling. Not just anger, rage. It is global, so big. Injustices, ugliness, death, despair regarding the beauty and life destroyed by humans. Outrage at the intransigence of those in power. I am screaming at them. Can't you see it? Things look so dark, as if less light in the world. And this very important note, humanity is pestilential. Raven is a bird of prophecy. The Proving of Raven, which was conducted in 1996, reveals a template astonishingly relevant to COVID-19. The phobia, the panic, financial collapse, sickness, suffering, suffocation, pre-existing lung and heart disease, emergencies, ambulances, lockdown, cancelled flights, packed hotels and airports, repatriation, waiting transport home, social distancing, confinement, isolation, loneliness, domestic friction, martial law, and ever-present death, a bird of death. Notable was the emotional intensity of journal entries, haunting fear of death, of poverty, of deprivation, of dereliction, forebodings of misfortune, doom, and death. Delusions has no defense or protection with panic and anxiety. She must protect herself, must be vaccinated. Danger, in great danger, family in danger. Life is surreal, as if floating between 2 dimensions. And I think many of us experience this sense of unreality during strict, severe lockdown. Feeling others suffering and pain, financial and business world falling apart, so scary when my lungs are not working fully. Scared I wouldn't be able to breathe. At a funeral, I cried so hard and yet could not cry enough. Getting lots of bad news, relatives and friends dying. Lockdown, dreams of confinement and imprisonment. Loneliness is a major theme. Wanting to be free and not being free. Dreams of home and antagonism within the family. Domestic friction, domestic violence. Officialdom, dreams of bureaucratic control, having to produce papers to identify to the authorities. Biometric passport. Fear of them, the men in black, punitive officialdom, martial law, loss of freedom, loss of choice. Vaccinate or else. The symptoms of this proving went to my life center, to the heart and the breathing, the feeling of what it would be to be dying. And then there is so much pain in this proving, emotional pain. The Irish associate Raven with a dread female deity, the Morrigan, the shape-shifting Celtic goddess of war, fate and death. The Morrigan is a raven goddess, often revealing herself as a raven. In battle, like a Valkyrie, she is the chooser of the slain, a battle raven, circling above the killing fields, the scream of the raven heralding the fall of a warrior. Now the Morrigan flies over COVID-19 world, choosing who shall fall ill, who shall not, who shall suffer, who shall not, who shall live, who shall not. She is the defender of the feminine and the protectress of order. The Raven goddess's function, choosing the slain, has never been more evident. C19 targets the old, the infirm, the obese, the compromised, and quite conspicuously males in its original form, largely sparing women, especially pregnant women, and the young. Hence, defender of the feminine, defending Gaia while protecting women and children, the most pressing concern of Raven. The masculine bias of the pandemic reveals COVID-19 as a planetary antibody mobilized against the predations of the masculine ego self. The COVID-19 pandemic, like all plagues before it and all that will follow, is essential to the health of Gaia and to the collective health of humanity. COVID-19 has evolved in a morbid morphogenetic field created by destructive human activity, a toxic field that has given rise to the redemptive coronavirus organism, just as the bubonic plague arose out of the superstitious, fear-fraught energy field of the medieval Dark Ages, as gonorrhea flourished in its depraved and decadent aftermath, as syphilis arose from the religious strife of the Reformation, as tuberculosis fired the genius and passion of the Romantic era, and the Spanish flu vented the planet's devastation and despair after World War I. The order the Raven goddess protects is the most vital order of all, survival of the fittest, the most primordial law, and the best science of all. In producing COVID-19, the instinctively perceiving vital force of Gaia emphatically asserts this law, an energy that must be expressed, must be fulfilled, not thwarted. In defiance of natural law, at every level, politicians and medical science attempt to block the pandemic by suppression, which must have grave consequences, since imploded energy is always corrupted energy. We must be alert and prepared for the consequences. For help, we need to consult the mythology of the bat. Like the wolf, the bat is the scapegoat of humanity, targeted through projection with all the resident malevolence of the human psyche. In its most diabolical form, the image projected onto the bat is that of the human vampire. Living exclusively on fresh human blood, an archetype close to Raven and Plutonium. The vampire is iconically embodied in Count Dracula, a personification of evil conceived by Bram Stoker, an Irishman, whose name Bram derives from Bran, the Irish word for raven, loops within archetypal loops. It was in Whitby, the Yorkshire harbour town, that Stoker first came across the name Dracula. It is at Whitby that Dracula springs from a shipwreck onto English soil. And Whitby is famous for jet, an intensely raven black, semi-precious carbon gemstone. Jet is a raven stone, a death stone, a stone of doom, gloom, and foreboding, a mourning stone associated with grief, bereavement, loneliness, morbid depression, and despair, a protector stone like Raven, able to ward off the evil eye and keep dark forces at bay. The psychopathology of Jet centers on the fifth or throat chakra, the chakra of communication and creativity, and communication through the creative arts, arts so sadly crippled by COVID-19. The related organs are the thymus and the thyroid. Jet's relationship to the thymus gland signals its role in cell-mediated immunity, the functional zone where COVID-19 unleashes its fury in the second week of infection, producing the cytokine storm, an uncontrolled, excessive autoimmune response that acts destructively, causing diffuse alveolar and capillary vascular damage, multi-organ failure, and death. Coronavirus is a virus loaded with miasmatic power derived from the human excesses and planetary distress that has brought about its advent. Raven informs us, destiny is written into the nature of the archetype. Ferum will go to war. Staphylos agria will be abused. Natrum muriaticum will be heartbroken. The presiding archetype warns of the direction a patient's life will take, often seen in practice. On a wider platform, pivotal archetypes such as Raven, Plutonium, and Jet forewarn not only the destiny of individuals, but the destiny of mankind. Jet's Dracula association relates the archetype to the marauding masculine energy of the ego-driven psyche. Although there are shadows of this presence in its remedy picture, Jet, like Raven, is largely an observer, registering the consequences of human abuse of nature and the consequences of fear-driven vaccination programs, and prophetically does so in harrowing terms. Superbug infections, viral or bacterial, causing necrotizing soft tissue inflammation, thrombotic and gangrenous consequences of capillary and arterial damage, proliferation of autoimmune diseases, immunodeficiency disorders, infertility, and diverse malignancies. These are the dangers. Jet's closeness to plutonium is confirmed in that even moderate radiation therapy may precipitate uncontrollable necrotizing radiation disease, something we see in practice. A key Jet indication is the swift onset of dangerous and destructive pathology in a deep, slow-acting chronic constitutional remedy. Like Raven and Plutonium, Jet may anguish over the wisdom of bringing a child into this tormented world. Jet warns us, never fail to guard against the consequences of COVID vaccination. Ill effects must occur, manifesting immediately or more commonly, like ionizing radiation, insidiously and remotely over many, many years, or remaining hidden, a blight then handed down to future generations through the continuum of disease. Thuya, arsenicum alb, and silica are well indicated as COVID vaccine prophylactics. But when these fail, Jet should be considered. Jet may well prove the COVID-19 vaccine prophylactic. It is particularly indicated for those who have been forced against their will to vaccinate through pressure of circumstances. I found it also a remedy for those who, in resisting vaccination, have been emotionally traumatized by social shaming, guilt tripping, and moral castigation, often coming from those close to them. However, when asserting freedom of choice leads to exclusion and pariah status, never forget spheniscus for penguin. I must reiterate, the homeopathic materia medica is a portal to a mysterious other world, more real than that which we now inhabit. I would implore all of us, like Alice, to step through the looking glass, that the waves we make may accord with the highest truth. In my book, The Raven, which I have subtitled A Flight Through an Archetypal Force Field, I invoke the mythical vision that makes these realms accessible. Those blessed with such vision are said to have raven knowledge, an Irish proverb meaning to see all and know all, to observe, to perceive, and to unravel matters beyond the comprehension of the ordinary mind. Thank you so much for your company and for the time you have given me to address you on most critical Raven matters. I will now be pleased to answer any questions you may wish to ask. Thank you so much.
Okay, now we will finish all presentations. Okay, Gustavo, do you have any?
I think some questions to Andre. Some questions to Andre Singh.
He answered already by the chat rooms.
Okay.
I saw them. And now, Gustavo, do you have any?
I'm going to make some comments. Sincerely, I love this speech of Professor Lily. Lily, I don't know if that's the correct pronunciation. I love it. This is an approach that could be very interesting in the reflections. For putting into the ground, into the earth, I want to say that in the yesterday in the poster sessions there were cases of plutonium nitricum as a remedy to help in the pandemic. So very nice this poetic presentation, and I cannot make many comments about Andrés Paine, a presentation. We all know him, a very good presentation. He brought a very interesting topic that it should discuss in all a webinar, the question of homeoprophylaxis, because what about, I could ask him many questions. For instance, if bryonia versus constitutional remedy, bryonia versus arsenicum, for instance, as homeoprophylaxis in India, as Dr. Kurana presented today, etc. So it is a very, very long discussion that it is not possible to make here. Dr. Bigliani talked about objectivity today, and Dr. Jennifer Jacobs about the research and the necessity of research in homeopathy. So I think that we could finish because we are very near, very close to the next session. So I don't know how I asked to our moderator how much time we are going
We
to
only
have
have 3 minutes
for the
more.
next.
Just 3 minutes?
Yes,
Okay.
we only have 3 minutes. So I would request everyone to please turn on their cameras and have a big smile on their faces so that we can have a great group photograph together.
Then maybe you can send us on WhatsApp.
Yes, surely.
Okay. Take
Can
it.
we all please turn on our cameras and put a smile on our face?
Okay.
Okay.
And thank you to all.
I think we have clicked a photograph.
Okay, done.
Thank you. Thank you so much. Thank you so much, everyone, for joining in. Thank you so much to our honorable chairpersons.
We can have 5 minutes because I'm the next chair session too. In the next session, please 5 minutes. Okay.
Yes. Thank you so much, everyone, for joining in. It was really
Bye-bye.
a very insightful and informative session. We are all about to start with the next session in 1930 hours CET. See you in the next session. Thank you so much, everyone, for joining in.
See you.
Thank you.
Thank you.
Thanks a lot.
Thank you for everything.
Thank you.
Bye-bye. Bye.